Thank you, Toby, for this very difficult talk which we had. And I think you've done a great job trying to clarify the issues which are related to PCOS and hyperandrogenemia, which is associated with PCOS. I'd like to open the panel for discussion. We do not have the Dr. Madhumita with us, so the liver part is unfortunately will not be discussed. But we will discuss the musculoskeletal, that is with Dr. Meeta, and you will discuss with the bone. There are a few questions which have come up, and one of the questions to Dr. Meeta is that you have mentioned that there is low vitamin D seen in these patients with the ones who are more sarcopenic. But don't you feel that, are you there, Meeta? Meeta, are you there? Can't hear you. You're muted.
Yeah, she's there. She's there.
You're muted.
She's muted.
Yes, thank you.
Hello, Duru. Yeah, I am at Varanasi on the road.
Okay.
So I will try to do my best. So please, can you come? There's a lot of noise over here.
Yeah. So
Yeah,
can I speak
noise,
again?
but
can I ask you the same question again?
yeah, please.
So the question is that women who are sarcopenic, where the muscle is concerned, and in PCOS you find that there is a sarcopenic obesity. You have suggested that there are low vitamin D levels found in them.
Yes.
Now we find low vitamin D levels in a lot of Indian women and in a lot of PCOS women. So would you be able to correlate it with this?
Yeah, Dhuru, I think that's a very interesting question, because when Toby was talking about doing a baseline DEXA for everybody with the PCO, the first thought that came to my mind was, probably we're a little premature at this particular stage, because we really don't have so much of evidence really to relate to sarcopenia. And like I said in my talk, in the early part, the body just like, raises the insulin to counteract. There is a little hypertrophy initially of the muscle. And then whatever studies have been done, the average age around 25, 30, where you have the peak muscle mass is almost the same. And if you're going to, conduct studies in these women, we find osteomalacia even in, your the BMD results, the osteoporosis, especially at the ribs and the sternum, the BMD would be less compared to the limbs and the cortical bones when you look at the DEXA reports. And probably the osteomalacia is working for PCOS and non-PCOS. We would really need studies to say whether it is different or whether it's, part of the entire thing, whether PCOS, but we know that it's an inflammatory state. So because it's an inflammatory state, we hypothesize that, these people are more prone for these chronic diseases like the cardiovascular, or be it the muscle or the bone, because once the body tries its level best to overcome the problem, and then it gives way, and then you develop diabetes. Once you develop diabetes, sarcopenia and osteoporosis is kind of part of it. So I think that's my understanding. And thank you, Duru, for making me read so much on this particular subject. There is hardly any material on it. And there are very few studies as well, that it's so interesting that, whatever it is, finally it boils down to good calcium, good vitamin D. And it's not just muscle strengthening, but I think it's very, very important to also concentrate on the, the aerobic exercises for the muscle. Though we always talk about this, but because muscle being a metabolic organ, so cardiovascular aerobic is also important, I think. Yeah. So, ma'am, that's the answer to Dr. Rama, that yes, vitamin D, we have to be replete. Like even in osteoporosis, we say, first thing do is correct the vitamin D and calcium before you give any treatment. So I think that applies even to sarcopenia.
Absolutely. So
we are at the Ganges just now, Sunila and myself, in the middle of a huge crowd.
So can you answer, or I'll go to Toby?
Yeah. So, no. Do you have any more questions for me?
Yeah, one more question for you.
Can I do that, because I found a little place where I can? Yeah.
Okay. So we have women who are sports women.
Yes.
And somehow sports women who are found to be having higher androgens in their blood when they are tested before they go for an Olympics or some kind
Yes.
of a championship. Unfortunately, because of their high androgens, they are not allowed to compete in the women's teams. I mean,
Yes.
how to react to that? I mean, what should we be doing as a PCOS society for such women? Because they find that because they're hyperandrogenic, they are probably having stronger muscles, they are having stronger bones, and therefore
Yes.
they're eating much better than the other women who are non-PCOS.
Yeah.
So I find that very unethical actually, but I don't know what we need to do about it.
Yeah, probably then, we should, all of us should do. I mean, that's a very interesting question, which is not actually related to the topic, but I think we should take that up because that's unfair, like you said, Guru. So we should conduct studies in these women, get their data out, the body composition related to the insulin and the androgen levels in the normal athletes and the PCOS, and say that hyperandrogenism per se doesn't, cause this problem, and they're absolutely healthy. And it's only because of the lifestyle their androgen levels are slightly higher compared to the so we have to probably give the people evidence. As a society, we have to generate the evidence.
So what kind of test would you recommend that we should do for assessing their muscle and their,
definitely DEXA body composition, where you're going to look at the muscle health, you're going to look at the fat health, you're going to look at the bone health. You also will know whether, the vitamin D, where the bone is more, where the, a complete segmental analysis of everything, and then correlate with all the hormones, and then come out with some concrete statements. You cannot just talk without this evidence.
Absolutely. And how often would you do the DEXA? Would it cause any excessive radiation to the women?
No. DEXA is absolutely safe. Safe. The radiation is like, just traveling around the world in the aircraft probably. And I think we can repeat it every 3 months and 6 months for body composition. If you want to have a follow-up kind of a thing, exercise program, then you want to see the change. 3 months is also good enough. 6 months is also good enough. So it depends on what program you have got them in, and you can repeat the DEXA to see the change in the muscle and the fat.
But Toby, would you agree to that? Would you do a DEXA every 3 to 6 months, or you would wait 2 years?
This is for body composition. I'm not talking about the DEXA for bone health. I'm talking about body composition.
Only body
composition. Which is very different from the DEXA that we do for osteoporosis.
Okay, so Toby, what do you think about the osteoporosis which is there in PCO patients? You said that, I mean, of course, the current evidence shows that PCOS women are... Meeta, can you mute yourself, please? Meeta, just mute yourself. Okay. Toby, sorry. What I wanted to ask you is that there was a suggestion you made that you need to do a Z-score for premenopausal women to look for osteoporosis. And when would you do a T-score for them, ever?
Okay, hi, Duru, nice chatting to you on this Sunday afternoon. Firstly, I'd just like to clear it that I did not say that you should do a bone DEXA on every PCO patient. I think you should just regard it as the factors for low bone density and make your assessment as with other people. But if such a patient who was previously diagnosed with PCOS reaches menopause plus previous PCOS, I think is a good indication, if possible, under these circumstances, to see what the peak bone density is, as she will then face a lowered estrogen immediately after that. So I think that just the first. The second one was actually a warning. If you do a DEXA on your PCOS patient at an earlier age, do not use the T-score, because the T-score compares the value to a menopausal or to peak bone density. And most of these patients will not yet have reached peak bone density. And then the very important aspect is that a Z-score of up to -2 is regarded as normal. So there's a wide variation. So what we often find is that premenopausal women are exposed to DEXA as unnecessary. People who are not trained to interpret these values will give these patients a label of osteoporosis and even treat them with bone-specific medication, which is absolutely wrong. So I actually give a word of caution with the lowered bone mineral density that is expected in PCOS patients to please be very careful on the interpretation of DEXAs before menopause.
Absolutely. And after menopause, what would you recommend?
Well, after menopause, it would be that the patient would be seen like anyone else. So we would do a bone mineral density test, and that can then, for your country-specific values, well, firstly, if it is less than a -2.5 at the spine or at the hip, the patient needs treatment as anyone else after optimizing calcium and vitamin D, etc. If the patient should then have lowered bone mineral density, in other words, a value between -1 and -2.5, which is also called osteopenia by some people, then you can use the FRAX calculation to see what the patient's expected rate of fracture is. And then you will treat according to your country-specific values for FRAX. We use the American ones if the risk of a spinal fracture or any major osteoporotic fracture exceeds 20% or hip fracture exceeds 3% for the next 10 years, we would consider bone-specific treatment. In most cases, you would start with the bisphosphonate. So I don't think that the treatment is going to be any different for the PCOS of the patient. It will depend on the specific values.
There seems to be a little bit of a conflict with androgens improving the skeletal muscle, in short, and
Yep.
androgens not helping with the bone.
I think it's a question of a relativity. The excess the androgen can have a positive anabolic effect on bone, but it's actually very little. The beneficial effects of androgen on bone is mostly through the atomization of the androgen and precursors by peripheral fatty tissue to estrone. So or to estriol. So in this particular so what happens with PCOS, I think, because nobody quite knows, is that the lowering in estrogen and the constant lowering actually in estrogen is not compensated for by the testosterone. It sounds a bit oversimplistic for such a very intricate topic, but that's about as far as we know today. People have looked at various aspects of bone, but there's no constant other factor that comes out. And I think the clue probably lies in it that everybody agrees that the negative bone effects is not that obvious in patients with a BMI more than 27.
Yeah. So I think everything seems to be very clear now, and we've had three brilliant talks in this session, and I think we've exhausted with the questions which have come in. And I'd like to thank you, Toby, and Dr. Madhumita and Dr. Meeta for their participation, and really enjoyed this session. Thank you so much for being with us. Thank you. Thank you so much.
Thank you. Thank you, Drew, and thank you again for the very kind invite.
It was a pleasure, Toby. Couldn't be anyone else besides you for osteoporosis, for the bone.
I had to dig very deep for this one.
Yes, I know. Anyways, it brings out a new aspect of bone.
Oh, yes. No,
Yeah.
once, so thank you for that as well. It enlightened me.
Thank you. Thank you.